Hello, good day everyone, and welcome to this second edition of our HELICON webinars. My name is Brecht de Vleeschouwer. I'm an epidemiologist at Cienzano, also coordinator of the HELICON project, and it's my pleasure to welcome you to this webinar. The aim of today's webinar will be to zoom in on prevailing social health inequalities in COVID and during the COVID-19 crisis, and specifically based on evidence from excess mortality researchers. So we have invited three scientists who have been performing research on excess mortality during the COVID pandemic, and they will provide us a variety of insights on social health inequalities. We will also have closing remarks from David de Waal, who is a staff member at the Interfederal Combat Poverty Service, who will try to make the bridge between the research activities and the feelings about inequalities in the field on the floor. Before we get started, I wanted to give you some insights in the HELICON project, which is the umbrella for this webinar series. The HELICON project aims to unravel the broader health impacts of the coronavirus crisis in Belgium. It is a Belspo Brain project which will run for 4 years, coordinated by Cienzano and conducted in collaboration with academic partners from Vrije Universiteit Brussel, Ghent University, Université Catholique de Louvain, and Katholieke Universiteit Leuven. So overall, we aim to look at social inequalities in the COVID-19 crisis and quantify long-term and indirect health effects. In addition to the work that we are conducting ourselves, we also aim to collect and disseminate any evidence that emerges in Belgium across these three main pillars. So today, of course, the focus will be on disseminating evidence on COVID inequalities, but other webinars have focused on long COVID and will focus on the indirect health economic effects of the crisis. So today, as mentioned, we have a number of speakers who will be introduced to you shortly. The closing remarks will be provided by David de Waal. During the webinar, we will ask each of you to keep your microphone and videos switched off so that we can focus on the speakers. The presentations will each last for around 10 minutes, followed by 5 minutes of time for questions, which you can type in the chat or ask directly by raising your hand and taking the floor. The webinar is also being recorded, and both the recordings and the presentations will become available via our website after the end of the webinar. So with that, I'm very happy to introduce our first speaker, Professor Johannes Spinovan from the London School of Economics, who will be giving us some initial insights in health inequalities during the COVID crisis based on research on excess mortality. So thanks once again for being here, and I'm very happy to now give the floor to Johannes. Thank you. Perfect. We don't hear you, Johannes, even though you're not on mute.
Now you hear?
Perfect. Yeah, we do. Thanks.
Sorry about that. Let me share again. Even 1.5 years into this, we still have problems. So this is working. You hear me and you see my screen?
Yes, everything is perfect now. Thanks.
That's fantastic. So you haven't heard that I thanked you already for inviting me. So thanks a lot for this great initiative. It's a pleasure to be here, and it's a pleasure to present the work that I've done together with Andre and Thomas. This is work we've done in the summer of 2020. So it's a little bit outdated in a sense, but the motivation is still very relevant. And let me start with that motivation. So as economists, we're extremely focused on trying to document and understand different dimensions of inequality. And I think that health inequalities, and especially the persistence in health inequalities, is really one of the major challenges, or has been one of the major failures, I think, of modern welfare states. And secondly, as economists, I think we're pretty good in trying to leverage new data opportunities. And one of these new data opportunities that has been very much exploited in the economics literature in say the past 10 years has been the availability of data from de-identified population-wide administrative registers. Think tax registers, social security registers, health registers, education registers, and so on. And all of these linked at the individual. So this has proven to be an extremely powerful tool to generate an evidence base to inform and evaluate policy. But unfortunately, I also think it's an underused tool. And it's also an underused tool in the Belgian context, where despite fantastic initiatives and great efforts as well, we're still miles away from the data environment and culture that we have in Scandinavian countries, or not even that far away, just in the Netherlands. Okay. So let me talk a little bit about the COVID research that we've done. A lot of work has shown that there is a strong socioeconomic gradient in the impact of the COVID pandemic. And that's both at the economic dimension and the health dimension. But we also know that a lot of the inequalities were already in existence before the pandemic. So the question that we're trying to get at is, to what extent has COVID worsened the existing health inequalities? Or has it simply confirmed the inequalities that already existed? Okay, so the way we've approached this is by focusing on mortality records, because this is a health outcome. It's a very extreme health outcome, unfortunately, that is readily available, and it's available at high frequency. So we've done this analysis in July 2020, thanks to Stadbel, where mortality records were updated until 2 weeks before we've done our analysis. So in July 2020, we've been able to do our socioeconomic analysis of the mortality rates during the first wave of the pandemic. Okay, so through Stadbel, we've been linking these mortality records to information on socioeconomic status, income, education, sector that people work in, country of birth, and so on. We have focused on excess mortality rather than on COVID-related mortality, because we're interested in capturing the causal impact of the COVID pandemic. The problem with studying COVID-related mortality is that we don't know what would have happened to people in the absence of COVID. Secondly, we're going to compare or contrast the conclusions of doing the analysis at the individual level or at the geographic level, because often we only have data available at geographic levels, but we'll show that this sheds light on very different mechanisms, and we should be careful when we're drawing conclusions based on the one dimension of data relative to the other dimension of data. Okay, let me get to our findings. Our major findings was that during the first wave of the COVID pandemic, there has been a very strong negative income gradient in excess debt, meaning that there have been many more extra debts in lower income groups than in higher income groups. However, and that's the second important finding, the income gradient in overall mortality has been comparable to normal times when you express it in relative terms. Okay, and then thirdly, we show that the income gradient is substantially steeper when we look at the municipality level than when we look at the individual level. So let me try to unpack these three major findings, and let me show you some graphs. So what we're looking at here is the income gradient in mortality for men and women that are aged between 40 and 64 years old. So what we see on this chart is two things. First of all, there is a very strong negative income gradient in the mortality rates. The mortality rates for people in the lowest household income decile is more than 3 times as high as the mortality rate for people in the highest income decile. That's the first thing we see here. Very strong negative income gradient. The second thing we see is that the mortality rates during the first wave of the COVID pandemic, so between March and May in 2020, has been basically exactly the same as in the 5 years before for this specific age group, and that within each income decile. Okay, so there is no excess mortality in none of the income deciles for this specific age group. That picture changes quite substantially if we look at the older population, if we look at people aged 65 years and older. There we see strong excess mortality, but we also see it in each of the income deciles. Okay, in the paper, we're also discussing, because we're excluding from this analysis, individuals in nursing homes, but I think we'll hear a little bit more about that later as well. Okay, let's zoom in the excess mortality for this specific age group. What I'm showing you here is this excess mortality in absolute numbers. And if you zoom in on this, you see very clearly that the excess mortality has been much higher in the bottom income decile compared to the upper income deciles. Okay, it's been more than twice as high if you go to the lowest income decile compared to the highest income decile. Okay, and it's similar for men as for women. So there have been more excess deaths in the lower income decile compared to the upper income decile when calculated in absolute numbers. However, if you express this excess mortality relative to the baseline mortality in normal years, you get this picture. It becomes very flat. The excess mortality expressed in relative terms has been more or less the same across all different income deciles. And that's true for both men or for women. So these findings are supporting the first two major findings that I tried to convey, that yes, low income groups have been hit disproportionately as measured by mortality rates, but in no way different compared to normal times. The baseline mortality rates are extremely unequal, and they haven't been more unequal during COVID times when expressed in relative terms. Okay, let me conclude with this last point, that the income gradient can be analyzed at a geographic level, for instance, at the municipality level in our context, or at the individual level. And let me quickly show you this table here. Okay, in this table, what we're doing is we're regressing individual mortality on individuals' household income, and we're allowing that gradient to be different during the COVID year. Okay, we're looking at mortality again between March and May of a given year. And what we see if we focus here on column 2 is that indeed the gradient has been stronger during the COVID months compared to what we see in baseline years. That's this negative coefficient here. Okay, if we go from equation 2 to equation 3, what changes is that we're controlling for municipality fixed effects. What this means is that in this regression tree here, we're comparing individuals with different income within the same municipality. And what we see is that this extra effect that we see during the COVID months has become smaller. This means that part of the difference that we see at the individual level are driven by where individuals live. Okay, so that's the first conclusion. Now we can also look at this, not at the individual level, but at the municipal level. We look at municipal income have had higher mortality rates during the COVID year. And we see that the extra effect during the COVID year has been much larger at the municipality level than it has been at the individual level. Okay? But once we control for some municipality characteristics, and in particular, once we control for the number of COVID cases at the municipality level, this extra gradient completely disappears. Okay? So what does this tell us? If we were to draw conclusions based on a municipality level analysis about the differences across individuals with different income, we would have exaggerated how bad the differences would have been at the individual level. Okay, so we have to be very careful. That doesn't mean that location effects are not important. They're very important at the individual level, but they don't explain everything. While at the municipal level, the big differences we've seen between communities with lower income versus higher income can be fully explained by the differences in the number of COVID infections that we've seen. Okay, let me conclude here, and I'm happy to hear your questions.
Johannes, thank you very much for this interesting presentation. My name is Laura van den Borre. I'm a postdoc researcher working at the HELICON project. So I think we have time for 1 or 2 questions from the audience. If somebody has a pressing question, they can raise their hands or ask the question via the chat. If not, maybe I can start, because I thought this was a very interesting presentation of an already very interesting article. I think it's very commendable that you provide so much context as well, so on the different income groups, as well as on the more general context of the household situation and nursing homes. And in this point, I was wondering, because you're an economist, what's your take on this? I mean, are you aware of different policy measures that have been taken during the COVID crisis that are targeting these groups that you have identified as perhaps more vulnerable? And what are your insights in this? Is income the main characteristics to be targeting in policy interventions, in your opinion?
So all good questions, very broad questions. I don't know whether I can do justice on this in a very quick response. I think as economists, we often look at just the economic impacts, and there as well, we know that people with low income have been hit the hardest, and there it's much more natural to target our specific interventions to lower income people. Okay, I think in terms of health consequences and health interventions, we have this often much less this natural reaction of targeting people with lower income indeed. I also think, like, when thinking about the differences at the municipal level and differences at the individual level, I think we were well aware, like in the midst of the crisis, that there were problems in municipalities with lower income levels, that COVID infection rates were higher, and we're confirming all of that. But I think we should be very careful in drawing conclusions from that, from what we're expecting at the individual level. At the individual level, we also see differences in pre-existing health conditions, and I think those are the main ones driving the big differences in mortality at the individual level. At the municipality level, it's mostly people's behavior, and in low-income municipalities, probably people's behavior, the infection rates have been different, but everyone in the municipality got affected by that, not just the lowest income individuals in these municipalities. So it's extremely important to separate the two things out. And it's an analysis we could basically do right away in the midst of when things were happening. And so my big message, and that's going back to my motivation, is we should do this kind of analysis much more routinely and at a much more comprehensive and standardized systematic way going forward.
I completely agree with you, and I'm happy to discuss this further with you after the webinar. I think we have time for one short question, maybe. Pierre Smith was the first to raise his hand, so I'll give the floor to him. Perhaps the other questions can be asked via the chat, and Johannes can answer them there.
Yes, happy
to. So Pierre, go ahead.
Thanks a lot. Very interesting presentation. So I'm working also in Sensano on the long-term impact of COVID-19. The results are on the first months of the pandemic. But do you think that you may have different results when looking at the longer term impact? Because, for example, in Belgium, a lot of care were postponed and delayed, and this may have an impact on mortality, but on the longer term. And there are also maybe social inequalities in this mechanism. So what do you think about this?
Well, I think a large driver of our results are these pre-existing health conditions, and I'm studying that in the Netherlands with much better data, fortunately, not related to COVID per se. But yes, I think we will see very similar effects if we look at long-term impacts, because we think that long-term impacts are also likely related to people's pre-existing health conditions. But we unfortunately don't have the data available to study this. And I know that this project here is doing great efforts to do so. But yeah, I hope that there will be much more analysis of this. And I'm concerned that the social gradient or the socioeconomic gradient will be as important areas.
Thanks.
Okay, perfect. As I mentioned before, the other questions can be asked via the chat box. And then I have now the pleasure to introduce Professor Katrien van Tomme. So perhaps, Katrien, you can start sharing the screen. Professor van Tomme is a sociologist, and she's a professor at the University of Ghent, as well as a postdoc researcher at the Free University of Brussels, the VUB. She'll be giving us some interesting insights into differences by migrant groups in excess mortality during the first wave of the COVID pandemic. Katrien, the floor is yours.
Thank you, Laura. Do you see my screen? Okay, great. So today I will present a paper that has been published already, a paper in collaboration with colleagues of Interface Demography and of Stadbel on migrant mortality differences during the first COVID wave. First, some graph that we all know. We know that there was a significant excess mortality in Belgium during the first COVID wave. And also from an international perspective, Belgian excess mortality peaked rather high. But of course, I'm always interested in inequalities. So the question we ask ourselves is, are we in this together? Several studies already have shown wide inequalities, being it by socioeconomic position or by pre-existing medical conditions. But less studies have focused on migrant backgrounds, which is exactly what we're gonna do in this study. So in the UK and the US, some studies have been conducted on this, and they generally observe that ethnic minorities are more vulnerable to contract the disease, but also to have worse outcomes. But less was known about continental Europe. As a previous speaker, this research was also done during summer of 2020. So in the meantime, of course, several papers have been published on this. Why is Belgium an interesting research setting for this study? As I showed you in the graph, it is a high-risk context in terms of COVID. And we also have quite a large proportion of people with a migrant background that is also increasingly aging. At Interface Demography, we have a long-standing tradition of research on migrant health. And actually, generally, we observe migrants' mortality advantage, which seems a bit odd since they are more likely to be in the lower socioeconomic groups. However, such a mortality advantage might be explained, for instance, by the theory of the healthy migrant effect, which is that there is a selection effect of migrants that are in good health that really migrate themselves. But COVID-19 is called a syndemic pandemic, which means that it's a pandemic that interacts with and even worsens pre-existing conditions and also social conditions. So this makes us think, well, is it really true? Will we also observe a migrant mortality advantage for COVID? So with this study, we wanted to look at the extent of excess mortality during the first COVID wave and look at differences, of course, between migrant groups and the native Belgian population. And secondly, we also wanted to look at the contribution of socio-demographic and socio-economic indicators to explain this differential excess mortality. To do so, we used a large individually linked population-wide data set consisting of the Belgian National Register for 2 years, 2019 and 2020, linked with the census of 2011. So for the total legal population in Belgium, we had information on the stock files of the total Belgian population at the beginning of each year. We also had information on socio-demographic indicators, socio-economic indicators, and all-cause mortality. So for this study, we included the total Belgian population aged 40 years and older. Since there is a delay in causes of death registration, we looked at all-cause mortality, and we aimed to calculate excess mortality during the first COVID wave in 2020, so weeks 11 until 20. And we compared this all-cause mortality during this specific period with the same weeks in 2019. Migrant origin was based both on own origin and parents' origin to be able to include both first and second generation migrants. And then we had a couple of variables of interest, such as type of households. So do you live with a partner, with children, which is actually a proxy of really close social contacts. And we also included an indicator on population density at the municipality level. Of course, for an infectious disease, some indicator on population density might be very informative. And as measures of socioeconomic position, we included educational attainment and income level. So we calculated age standardized mortality rates by migrant group, gender and age, both in weeks 11 till 20 in 2020, and compared these age standardized mortality rates with the same weeks in 2019. As such, we were able to calculate the absolute difference in mortality rates, in mortality, and also the percentage of change between 2020 versus 2019. We also looked at relative differences by calculating age-adjusted mortality rate ratios. So we calculated the mortality rate ratio of different migrant groups compared to native Belgians, with and without adjustment for the variables of interest. We had a lot of findings, but today I will focus on the most striking results. So first question was the extent of excess mortality among the youngest age group, so 40 to 64. We observed increased mortality in all origin groups, but only significant among native Belgians and sub-Saharan African men. Although this group was rather small, so we have to be cautious with that. A totally different view among 65 year and older. There we observed a high excess mortality among all groups, both Belgians and all origin groups. So here you see the excess mortality in orange is 2020, in blue is 2019. So for instance, among Turkish older men, there was an excess mortality of about 38% in 2020, so during the first COVID wave, compared to the same weeks in 2019. Now, the second question was relative differences. So the differences between mortality among migrants versus native Belgians. Among the youngest age group, again, we observed relative few mortality differences. For one group, we observed a mortality disadvantage, so they had a higher mortality compared to native Belgians. So sub-Saharan African men and women had a mortality disadvantage compared to Belgian men and women. However, when we accounted for the socioeconomic position and the demographic indicators of in our models, this disadvantage disappeared. And secondly, we observed an advantage for Northern African men and women and Turkish women, which is actually in line with what we usually observe. Among the oldest age group, overall there was a trend towards a mortality disadvantage among migrants, but the most striking result was the mortality disadvantage among Turkish men, which was really high and which is opposed to the normal mortality advantage which we in usual times observe. When we accounted in our models for the demographic and socioeconomic reality of these groups, we actually, we observed a decrease of mortality among most migrant groups, except among these Turkish men. So they still had a mortality disadvantage, even after controlling for their demographic and socioeconomic position. And in addition, we observed a mortality advantage among Northern African men after controlling for socioeconomic position. This is the graph showing this. So for instance, in the age-adjusted models, Turkish men had a 46% higher mortality compared to Belgian men. And after controlling for socioeconomic and sociodemographic factors, they still had a 28% higher mortality compared to Belgian men. And we see that in the age-adjusted model, there was no difference between mortality among Northern African men and Belgian men, whereas after controlling for socioeconomic position, we saw a mortality disadvantage. So the mortality of Northern African men was about 20% lower than Belgian men. Before jumping to the conclusions, just some small methodological remarks. So we used an exhaustive data set with a linkage which provides us a wide variety of indicators. However, we did not dispose of data on undocumented migrants. Even though it was population-wide, some groups were rather small, so we have to be cautious. We were not able to distinguish first and second generation migrants in our models because of small group sizes. However, we tried to make a proxy for that by dividing by age. And of course, we did not have cause-specific mortality. And nor did we have data on other important determinants of mortality, such as occupation, but also health-seeking behavior. And in terms of this research, especially language barriers are quite important. So to conclude, no, we are not all in it together. We observed striking inequalities, and especially in the light of the healthy migrant effect of the usual observations of the mortality advantage among migrants, these inequalities were striking. And even after accounting for their socioeconomic and sociodemographic reality, they were still significant, which probably points to the fact that other things are at stake, such as cultural differences. For instance, the difference between Turkish men who had a disadvantage and Northern African men who had an advantage makes us hypothesize that language barriers are very important in that regard. In terms of policy, of course, we can conclude that a one-for-all policy might not work. But we have to keep in mind this was a first wave, which was, the second wave or the months thereafter, measures were taken to really address these specific groups. So we are curious to see in the next periods what will be the results. So I thank you, and I'm open to answer your questions.
Thank you very much, Katrien. It was a very clear and interesting presentation that will definitely give a lot of us food for thought. But considering the time schedule, I'm going to ask people that have questions for Katrien to ask them in the chat box. And Katrien, maybe you can answer them there
Okay.
during the course of the rest of the webinar.
Okay.
That leaves me to present our last presenter of his research, and that is Dr. Olivier Hardy. Olivier is an evolutionary biologist and a plant geneticist at the Université Libre de Bruxelles. Olivier, you can start sharing your screen.
Yes, I just try to find how we do it. Just a minute, sorry.
No worries. So next to the stop video button, you will see a share button.
Yeah, but it's because I have a long list of maybe, no, this is not. It's, well, I will maybe share my whole screen and then, do you see my whole screen?
Yes, we're seeing the WebEx now.
And now,
yes, perfect.
Is that okay?
It's great.
Okay. So sorry for the delay. So, so thank you for inviting me. This is a work now focusing also on the first COVID wave in Belgium, but more specifically in Wallonia, and that was done in collaboration with researchers from ULB, UCL, Cienzano, and AVIC. And yes, 1 year ago we published already a preprint, and now new version is accepted in demographic research. So what we wanted to do is to study mortality in care homes for elderly people in Wallonia. And so we considered, I would say, two distinct populations. First is the resident of care homes, so we call here facilities for elderly people, and where we distinguish two categories: the nursing home sensu stricto, where you have, of course, old people, but a proportion of them require health care. So those are institutions with rooms or beds equipped for medical assistance. And then you have homes for elderly people that house old people, but that usually require less in relatively good health, I would say. And so the difference between the two is the proportion of nursing staff per resident between the two. And then the other population is simply all the people not living in facilities for elderly people. And so we concentrate to the first epidemic wave, to the number of deaths that occurred in those two populations. So what you see here is the cumulated number of COVID deaths. In gray is for the care home residents, in green the rest of the Walloon population, and you see that it's about 2/3 of deaths occur in care homes. And it's interesting to look this across time, because you see that for the 3-4 first weeks of the epidemic, actually it was outside the care homes that there were the majority of deaths, and then it inverted. So there is a delay contamination of care homes compared to the rest of the population, which is quite logical if we imagine that it's probably visitor or the personnel of the staff of care homes that somehow brings the disease inside. Now, it's also interesting to consider the mortality that occurred in the different care homes institutions. So, and because it's very heterogeneous, for the first wave, there was no COVID deaths in more than half of the care homes. But we have situation here, you have accumulated proportion of care home institution according to the death rate that they observed, and with different lines corresponding to different situations. But we see that there are extreme cases where up to 20 or even 30% of the residents died from COVID. So it's really tragic situation. And on the other hand, you have many cases where there was no death at all. And if we separate nursing homes and homes for elderly people, already we see quite a big difference in the mean mortality rate that were obtained. And if in each case we separate by size, so small size versus medium size for the homes for elderly people, or medium size versus large size for nursing home sensu stricto, we see that it has a strong effect on the mortality rate that we observe. So this clearly show that there is higher contamination that was observed in larger facilities, even if we consider the type of facilities, and generally higher, probably higher contamination in facilities with more nursing staff. I also looked a bit at the geographic trends, and actually there was no large-scale geographic trends, but a trend that closed institution had a bit more similar mortality rates. So those are the numbers, and we see so about 64% of deaths occurred from care home residents, while care home residents represent only 1.3% of the population. So if we compare the raw mortality rates between the two, we make the fraction, we obtain a very high difference, 130 times more death in nursing homes compared to the rest of the population. So the question is, what caused this high difference? Of course, there is certainly the age pyramid. We imagine that residents of care homes have are not so healthy, and there could be also difference in prevalence of the virus inside and outside care homes, and maybe difference in healthcare quality, but this is not something that we could really assess. So how to somehow decompose this number in terms of these different possible causes. And for this, so we compute these sex and age specific mortality rates for COVID, but also for all annual mortality in a non-COVID year. And each graph represents so the mortality rate in per thousand, but on a logarithmic scale according to age class. This is for COVID, and then the two lines above are for the population living so in care home institution. It's higher for men than for women, and that's for the rest of the population. And it's interesting to compare this COVID mortality with the annual mortality. We see that actually the shape of the relationship is very similar. It's nearly a linear increase of the logarithm of mortality with age. So that's so-called sometimes Gompert's law. We also see that higher male than female mortality at the same age, but with a difference that the difference is higher, is about 2.1 for COVID deaths compared to all-cause mortality. And this is a kind of signature that could be found elsewhere. And of course, a much higher at same age mortality in care homes. If we now want to have to take into account the effect of age pyramid, well, here you see in yellow the age pyramid in care homes, with of course all people, but also quite large excess of women compared to men. So if we integrate this information into those curves, what we can estimate is that only the age pyramid explains a 11 times higher mortality level in care homes than outside. But 11 is still very far from the 130 times ratio that we observed. What about the other? If we want to consider the health frailty, here that's why the annual mortality is very interesting, because the difference between mortality in care homes compared to the rest of the population, but at the same age, is a measure, a direct measure of health frailty. And this measure tells us that on average, we have a 3.8 times higher mortality rate in care homes. So this is the two effects that we can control. And to reach this 130 in some way, we can assume that to explain this high difference, it should be that there is higher contamination in care homes, because we have here a much higher difference between care homes and the rest of the population for COVID mortality than for annual mortality. So that's how we could estimate that there is probably 3.5 times more incidence of the virus in care homes. So this is about the estimation. Of course, the two first effects, age pyramids and health-free, are constitutive effect of the care home population. We cannot do much about it, but the contamination rate calls for a specific response. And according to some serological studies that were conducted in the general population, estimated that after the first wave, we had around 6-7% of the population who had been contaminated. That times 3.5, that would mean that about 20% had been contaminated in care homes. So what are the factors facilitating the introduction of transmission of virus? Well, quite obvious that frequent contact with the outside world, especially in large establishments, more frequent visits would be a main factor for the entry of the virus. It's a close community. Staff must meet people in different groups, so a faster dissemination within each care home. And then, of course, during the first wave, there was a lack of protective equipment, a lack of preparedness, and so that's probably also exacerbated the epidemic at a very local scale. Now, I also looked just last week, actually, to look a bit how do these results compare with the next wave that occurred and also in the other region of Belgium. So what I represent here is the number of deaths per week for care home residents in red, for the rest of the population in green. In Wallonia, so we see the first, second, and third wave, and then in the other region. So if you look at the second wave, actually the second wave was worse for the rest of the population in Wallonia, but less worse for the care home residents. And so this means that from about 2/3 of the COVID deaths occurring being care home residents, it drops to 45% during the second wave in Wallonia. There can be, of course, many reasons for this, but one possible effect that could have been important is that from mid-November, there was a systematic testing, I think every 10 days in each nursing home. And this might have been very efficient to limit the propagation. For the third wave, so starting from mid-February, there we see that it's only less than, well, about 11%, and that's really the effect of vaccination, which was very efficient. If we now compare with the different regions, the first wave were very similar in Wallonia, Flanders, and Brussels, except that in terms of relative mortality, Brussels was nearly 2 times more affected. So that would mean that in care homes, if the estimate of about 20% contamination in care homes in Wallonia might correspond to something like 40% in the care homes of Brussels. And this might have been an effect for the rest. If we look at the second wave, well, there we see quite difference between the regions. So I explained the case of Wallonia. In Flanders, on the contrary, the second wave was also very deadly. It was actually not that bad for the rest of the population, at least compared to the French-speaking part, but in care homes, it was still very bad, and the epidemic lasted quite long. And I don't have clear explanation, but if I'm correct, there has been no measure like systematic testing in Flanders. In Brussels, we see also much less a reduction of the impact for care home residents. And here I suspect that the very high level of contamination that would follow the first wave might have had actually was a kind of group immunity to some extent for the second wave. Anyway, if we now look at the scale of Belgium, if we consider what happened after the two first wave, well, we must observe that about 9% of care home residents that had died from COVID. And this is a rough estimate I made recently. It has not been really discussed with other people, but according to different lines of evidence, I estimated about 60% of care home residents had been infected during the first or the second wave. So this is 3 times more than for the rest of the population. So, well, as a conclusion, care homes are very specific context for COVID. Population highly vulnerable, difficulty to avoid viral transmission. I'm not doing epidemiological models, but given the difference in dynamics and transmission, I think it would be good that those models actually consider 2 compartments, the care home residents and the rest of the population. And as a practical recommendation, at least before vaccination, now it's not that much a problem today, but it's really management measure to limit the introduction of virus and the viral transmission within care homes that should be efficient. So there is probably a good effectiveness of systematic testing in Wallonia if we compare it to Flanders, and clearly a very effective effect of vaccination. So, thank you.
Thank you very much for this presentation, Olivier, especially for the nice surprise of updating with the second and third wave. I've noticed that there's already a question in the chat box, and I would like to invite other participants of this webinar to do the same with their questions. And considering the timing of this webinar, I would like to introduce now our next speaker for the closing remarks, which is David de Waal. And we would like him to share with us his insights into these presentations. David, you have the floor.
Thank you, Laura. And thank you for everybody for presenting the interesting research here. I would like to start with a general observation, and that is that these studies confirm the observation that at least during the COVID crisis, existing social inequalities were reproduced. And oftentimes, people in precarious situations were probably more strongly affected by the negative consequences of the pandemic, as opposed to people of middle class and up. It was also phrased like that by the Flemish Societal Relance Committee, which existed at a certain point, that people in certain groups are more severely affected by the negative impact of the crisis and are benefiting the least from the positive trends that also occurred. And this all, during the pandemic, caused existing vulnerabilities to deepen and to make the group that is struggling to cope with surviving at that point to get broader. And I myself was struck by how soon people in poverty came into trouble when the lockdown started. It was almost immediately after the first days of the lockdown that we received signals from organizations who work closely with people in poverty that because some stores didn't accept cash payments, because the closing of social restaurants, closing of meeting spaces for people in poverty, that some people and some families were early on struggling to get by day by day and were even having trouble getting food. And I would like to illustrate this closely. It's not directly related to the studies that were presented, but a few other domains where this trend occurred. It was also very prominent in the housing situation, where it's a lot more difficult and probably a lot less safe to occupy a small space, small apartments, no access to nature during the lockdown. There was also the inequalities in job contracts. For example, you have the system of flex contracts, which received no compensation, while exactly these kind of jobs are very important for people living in a precarious situation to be able to afford essential goods and services. Another telling example, I think, are the savings, where you have in general a rise in savings during the period of the lockdown. But if you look more closely, you see that some categories and higher middle class categories were able to save money during the crisis, while other categories, namely lower income categories or people with flexible contracts or less sure labor contracts, almost had no savings to start with and had to use it all up during the crisis. And that's something that we observe in all important domains of life, based on the research that is already available, but also based on signals we receive from organizations who work with poverty. And we collected that in a note on the impact of the COVID crisis on people in precarious situations, which can be found on our website. Now, to look more closely at the studies that were presented concerning Professor Spinovan's conclusions, it struck me that the fact that the social gradient of excess mortality is equal to the social gradient in normal times, because I think that's still very problematic. This social gradient is well known. And there was a major commitment in that time to prevention during the COVID crisis. There was an unprecedented prevention campaign, I think. And we didn't succeed as a society to protect the people that we know were at risk more than other people to have severe consequences of a COVID-19 infection or to be more exposed to COVID-19 contaminations. And the existing inequality was reproduced. So I think that's something that would be very interesting to dive deeper into the reasons behind our failure to address the social gradient and the gap in health between people who are having a decent income and people with lower incomes. Concerning the study of Professor van Tomme, I think the multidimensional approach is very interesting. It's very interesting to look at the pandemic as a systemic pandemic, and because this exposes points that are relevant to the unequal social consequences of the pandemic too. I think that we can interpret these results within a framework of intersectionality to look more closer to why certain communities are especially struck by the consequences of the pandemic. And I think this also is linked closely to the nature of poverty, which is multidimensional in nature too, and which has a strong interplay between all different dimensions, which probably worsens the effects of which can be observed on one dimension. The study of Professor Hardy is harder for me to reflect on because socioeconomic factors are less present there, and the study of Professor Spinovan noticed no socioeconomic effects in nursing homes, and these are really, in fact, worlds apart. But I think it will be interesting to see or to notice what the effects of this crisis will be on the future of nurture homes. And I'm a bit worried that it might lead to a larger differentiation in nursing homes and the facilities they provide with socio-economic divides between nursing homes and the services they can provide. So to have a few conclusions, I think that the COVID epidemic is something that we observed on other dimensions too. We published a report on sustainability in 2019, in which the large conclusion was that existing inequalities were reinforced by climate change and climate policy. That's something we saw in the floods of last summer too. And that's an observation we also have to make at COVID-19. And I think we have to question ourselves as a society why we can't address these social gaps and keep on reproducing them. I think the studies presented today really show the need and the value of systematic use of socioeconomic variables in research. I think it's, for example, the effect of the health measures and the pandemic on mental health is something a lot of people are worried about and very interesting. I think it's very important to look at socioeconomic variables in that research too, but it's not always available. I think we also have to frame these findings as a problem of non-take-up of rights. One of the comments in this chat also talked about the difference in vaccination rates. And I think we have to see this as a right on healthcare, and we have to ask ourselves the question why this right on healthcare isn't realized for all people in Belgium in equal proportion. I think this always also stresses the need for a multidimensional approach, because poverty is a multidimensional problem. I think the study, as I said, the study of Professor Tomme clearly showed this. And to conclude, the parts of the paper where the points of discussion are presented, I think it would be very interesting to cross knowledge to really address those questions. And crossing of knowledge contains, and that what we try to do with the Federal Combat Service too, is on the one hand, use the findings produced by academic research and kind of academic knowledge that was presented today, and cross it with the knowledge of social workers and other people in direct contact with people living in precarious conditions to really interpret the results and look for the causes and consequences of what is presented here. And thirdly, and most essentially even, combine this with the knowledge of people in poverty themselves and the experiences they had during the COVID-19 crisis. Thank you very much.
Yeah, perfect. Thanks a lot, David. Thanks for these important insights and telling examples that allow us to make the link between the research findings and the ground reality of poverty and inequalities. Thanks also for the very nice summary of conclusions and take-home messages that we indeed as researchers should all try to act upon. I think it's also clear from the webinar that we are still in the very beginning of understanding social inequalities in COVID and during the COVID pandemic. It is of course clear that COVID is a parasite that grows on inequalities and makes them even worse than before. But because of the issues that we have with availability of data and possibility to link data, it is taking for everyone a lot of time to start to quantify these impacts. So we are at the very beginning of unraveling the impact on inequalities, and I'm confident that as time goes by, we will learn a lot more about what the impact is and has been. And I'm very much looking forward to work with everyone here in the group to get a better understanding of these impacts. So we are very happy to learn from you, and of course also to present the findings that we will generate as part of our HELICON project. So with that, I want to thank everyone for being here. A special word of thanks to the different speakers. Thanks also to Laura for moderating the questions and answer sessions. If there are any unanswered questions, we will follow up on that by email, and you will also receive an email when the recordings and presentations are available online. So thanks once again, and we look very much forward to seeing you again in our next webinar, which will take place in a couple of months and might focus on the links between cancer and COVID, as a small scoop to end this presentation. So thank you, everyone, and I wish you all a very nice afternoon and a nice day. Thank you.
Thank you. Goodbye.